Good evening and welcome everyone. On behalf of Zydus, I, Dr. Suyash Bharat, welcome everyone. I would like to thank MSG for this wonderful opportunity. And with this, I'll hand the session to Dr. Amit sir. Over to you, sir.
Thank you, Dr. Suyash. Let me share the screen. Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Anand Patel from Chicago, USA, and he's going to lecture us on accelerated and blast phase of myeloproliferative neoplasms. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by Zydus Dedicated to Life, and very well managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan, and team from Zydus, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Dr. Anand Patel from Chicago, USA. All our discussants who are themselves very eminent hematologists as well as medical oncologists, and you participants for sparing a Saturday evening, morning, or afternoon from whichever part of the world you're logged in. Tomorrow, it is Sunday, 19th of October 2025 from 11:30 a.m. Indian Standard Time and 7 a.m. London time. You're Dr. Claire Harrison from London, UK, speaking to us on polycythemia vera treatment in 2025. Let me introduce our discussions for the day, and they are displayed here in alphabetical order. I will pause for a while for you to have a look on all our discussions for the day. They are eminent hematologists, hemato-oncologists all across the country. So these are our discussions for the day. Some more over here. Well, so now it's time to introduce our guest speaker for the day. We are with us once again, Dr. Anand Patel from Chicago, USA. Let me introduce him once again to all of you. He's an assistant professor of medicine, director of the Inpatient Leukemia Service, and associate program director for the Adult Hematology Oncology Fellowship at the University of Chicago. He also serves on the NCCN panels for AML and MPNs. He received his MD from University of Missouri, Columbia, where he was also elected to the Alpha Omega Alpha Medical Honor Society. He then completed internal medicine residency at the McGaw Medical Center of Northwestern University and served as chief medical resident. Subsequently, he went to the University of Chicago for Adult Hematology Oncology Fellowship and served as chief fellow. He's an expert in the treatment of acute leukemia and myeloid malignancies. He's also an active clinical investigator with a focus on developing novel approaches in the management of myeloproliferative neoplasms. He's particularly interested in improving outcomes in patients with accelerated and blast phase myeloproliferative neoplasms. Today, he's going to lecture us on accelerated and blast phase of myeloproliferative neoplasms. Well, thank you so much. I stop over here. Over to you, Dr. Anand Patel.
Thank you so much for the kind introduction, Dr. Khurana, and I feel so lucky to be able to join you all on a Saturday and join on the same weekend that Claire Harrison is also giving a talk. So I feel very, very fortunate to be part of the folks that are giving you lectures this weekend. Let me go ahead and share my screen. And I'd mentioned, Dr. Khurana, my connection is not the best, so I'm going to go ahead and turn off my video during the presentation part. So I'll do that. And can everyone see my screen?
Yes, please go ahead.
Okay, excellent. So with that, let's go ahead and get started. So as mentioned, my name is Anand Patel. I'm at the University of Chicago, where I focus on taking care of patients with acute leukemias and MPNs, MDS. And today I'm going to be focusing on accelerated blast phase MPNs. These are my disclosures. And really, my objectives over the next 45 minutes or so are to start by providing an overview of Philadelphia chromosome negative MPNs, discuss the prognostic tools and treatment considerations that we have in chronic phase myelofibrosis, and then spend the bulk of my talk focusing on accelerated blast phase MPNs. So we'll be looking at the risk factors for progression of disease, how patients are faring with our current treatment modalities, and then lastly, look towards the future and talk about what novel therapeutic approaches may have benefit for accelerated blast phase MPNs moving forward. I always like to frame conversations in the context of a case. So we'll have a case that will kind of walk us through different parts of this journey for a patient with an MPN as well. So this is a 60-year-old gentleman with PV. It was diagnosed 15 years ago, and he's presenting with constitutional symptoms and abdominal illness. He's kind of been experiencing what I call the honeymoon period, and that his phlebotomy needs have actually been decreasing over the past year. He's on hydroxyurea and he's on aspirin due to a prior thrombosis. And on physical exam, he has a very large spleen. On lab work, he has a very mild anemia. Platelets are normal and a mild leukocytosis. And the peripheral smear shows leukoerythroblastosis, some teardrop cells, no circulating blasts. The bone marrow demonstrates progression to myelofibrosis. His karyotype is normal. And then on molecular mutations, there are some high-risk mutations, including ASXL1 and TP53 noted, in addition to JAK2, SRSF2. So as I kind of go into this, I want the audience to be thinking about what the next steps in management would be for this patient. So as a reminder, when thinking about pH-negative MPNs, there are really three disease phenotypes that we think about. There's polycythemia vera, which is typified by erythrocytosis. Virtually all patients have a JAK2 mutation, and these patients carry an increased risk of thrombosis and an increased risk of progression when compared to ET. With ET, the main laboratory finding is going to be thrombocytosis. On bone marrow, it's usually normal cellular and there's proliferation of megakaryocytes, but the megakaryocytes look fairly normal. You don't see clustering, atypia, some of the things that you can see in myelofibrosis, but not in ET. In terms of the driver gene breakdown, about 60% of patients have a JAK2 mutation, another 30% of patients have a CALR or MIPL mutation, and then about 10% of patients have what we call triple negative disease, so they do not have one of the canonical driver mutations. Paradoxically, with ET, you do have to remember that there's an increased bleeding risk, particularly in those with extreme thrombocytosis due to acquired von Willebrand disease. And then lastly, we have primary myelofibrosis, which carries the most variable course with it. So primary myelofibrosis can have very different blood count abnormalities depending on when in the course someone is caught. So early on, you may have cytoses. As you get to the more fibrotic phase of disease, you can have low blood counts. The bone marrow itself will show megakaryocytic proliferation, atypia, and then you'll see reticulin fibrosis as well. Much like ET, about 90% of patients will have a driver mutation, and then another 10% of patients will be triple negative. And primary myelofibrosis has the worst prognosis associated with it in comparison to PV and ET. And triple negative primary myelofibrosis has a particularly high risk of leukemic evolution. So when thinking about myelofibrosis, we know that not all myelofibrosis behaves the same. There are some patients that can live with their MF for decades. There are others who need a transplant within a year or two of diagnosis. So with that in mind, our prognostics tools have become greatly refined over the last 15 years or so. We've gone from largely clinical information alone with the IPSS and the DIPS. We then added cytogenetic information with the DIPS Plus, and now we live in what I call the molecular era of prognosis, where you're incorporating high-risk mutations into scores such as the MIPS, the MIP70, the GIPSS. And I will say the list of high-risk mutations only seems to grow longer. You know, we have these well-defined mutations that are incorporated into our risk scores, but for example, we know that Sybil mutations, we know TP53 mutations, we know RAS mutations, all are associated with higher risk of disease progression and lower overall survival. So in terms of my management approach to pH-negative MPNs in the chronic phase, really what I think about is the risk lies in progression to myelofibrosis or to the accelerated or blast phase of disease. For those that have lower risk myelofibrosis, they can typically be managed with active surveillance alone, particularly if they're asymptomatic. For patients who are symptomatic, particularly due to spleen burden, you should think about JAK inhibition. In the United States, we now have 4 approved JAK inhibitors: ruxolitinib, fedratinib, pacritinib, and momelotinib. And then really for your higher risk myelofibrosis patients, the biggest consideration is referral for transplant evaluation if they are an appropriate candidate. Now, JAK inhibitors, while very effective at controlling symptom and spleen, there are significant limitations to the disease, to the drug class. First of all, the main side effect we worry about are cytopenias, which can be dose limiting. There is a very modest anticlonal effect, so they don't seem to eradicate the clonal mutation of MPN cells. Um, Use of JAK inhibitors does not impact the rate of progression to blast phase. And to give an example of how patients do long-term, the COMFORT-1 study, which looked at the use of ruxolitinib in myelofibrosis, at the 5-year follow-up mark, about 75% of patients were no longer on ruxolitinib due to intolerance, progression, or other reasons. So most patients within 5 years will not be on a JAK inhibitor. So when it comes to myelofibrosis, there are a number of targeted therapies on the horizon, some of which are summarized here, and some of which have already been investigated in phase 3 studies, such as the BCL2, BCLXL inhibitor, navitoclax. You've got IDH inhibitors. You've got the MDM2 inhibitor, navtemadlin, which is currently being looked at, telomerase inhibitors like imetelstat, LSD1 inhibitors like bomedemstat, and iadademstat, and then the BET inhibitors like pelabresib. So a number of drugs that are being studied in combination with JAK inhibitors for myelofibrosis. Now let's go back to our patient. So when we calculate the risk scores for our patient, he's intermediate 1 by DIPS and DIPS plus, but high risk by MIPS. Ultimately, because of the large spleen, he was transitioned from hydroxyurea to ruxolitinib. He was referred for allogeneic transplant evaluation, but ultimately decided not to proceed with this and felt much better with starting ruxolitinib. Unfortunately, after 18 months, the patient had worsening symptoms again. His spleen is getting larger, and now he has developed severe anemia, thrombocytopenia, and worsening leukocytosis with lots of circulating blasts, about 25% blasts. A bone marrow biopsy is done that shows grade 3 fibrosis in 26% blasts. The patient has acquired a monosomy 7 in terms of the cytogenetics. And on next generation sequencing, there's now a IDH2 mutation and an additional TP53 mutation that were acquired. So this patient has now progressed to the blast phase of MPN. So how do we define blast phase and accelerated phase? The first point I want to make is once an MPN has greater than 10% blasts, it's essentially behaving like an acute leukemia. So in my mind, I don't really differentiate between accelerated phase and blast phase disease. Now, technically, accelerated phase is 10 to 19% blasts, and blast phase is greater than 20% blasts, otherwise known as post-MPN AML, secondary AML, has many other names. And really, the goal of managing these diseases is thinking about achieving a remission if you can, and then proceeding with a transplant with curative intent in someone who's an appropriate candidate. Now, what are the risk factors for transformation? As we discussed earlier, primary myelofibrosis carries the worst prognosis of the 3 chronic phase MPNs, and part of that is driven by the increased risk of progression to blast phase. So this was work that was published now 10 years ago or so by Teferi and colleagues. And when you look at the rates of progression, in ET, the rate of progression to blast phase is about 4 years at the 20-year mark. In PV, it's about 7 years. And in primary myelofibrosis, it's about 14%. So as we have patients that live better and longer with their chronic phase MPNs, I do think we're going to see more and more people live long enough to have progression to blast phase. So that's something that we will have to be keeping an eye out for as we get better and better at reducing thrombosis risk in these patients early on and better control of their blood counts early on. Other risk factors to consider for transformation. So we know that both primary and secondary myelofibrosis carry an increased risk. Patients who have a high circulating CD34 count and post-PV primary myelofibrosis, and older patients are at risk of transformation. Cytoreductive agents carry a risk of transformation as well. The ones listed here, such as phosphorus, busulfan, pipobroman, are not ones that I use in my clinical practice anymore at this point, now that we have things like interferon, hydroxyurea, anagrelide, and even the JAK inhibitors to help control blood counts as a cytoreductive agent. Laboratory parameters, so we know that, of course, increasing blasts will predict a progression, severe thrombocytopenia, transfusion dependence, and then marked leukocytosis. Unfavorable karyotype by DIPS plus. And then the last thing I'll mention is the risk scores that we use for primary myelofibrosis. not only do they predict the risk, predict overall survival, they also predict risk of progression to blast phase. So a good example is in the MIP70, the very high risk category has a hazard ratio of 13.3 when for progression to blast phase compared to low risk. So patients are 13 times more likely to have their disease progress to blast phase in the very high risk category compared to the low risk category. So when thinking about why progression happens, really what it comes down to is, in general, it's the acquisition of several high-risk mutations that can happen within the chronic phase MPN population or a wild type population, which then leads to differentiation block and the accumulation of blasts that then allow for the development of accelerated or blast phase disease. The other thing that makes blast phase somewhat difficult to characterize and treat is that the route of progression can be very different for each patient. You can have what's called the JAK2 negative route of progression, where you have a JAK2 negative cell that picks up a high risk mutation like TP53. You can have multiple hits, so the accumulation of several mutations in a JAK2 mutated cell that then develops blast phase disease. Sometimes you don't even have additional mutations that are picked up, and the patient remains just JAK2 mutated and has progression of disease. So this is a very molecularly heterogeneous entity when thinking about accelerated blast phase disease. And because of that, it makes treatment that much more difficult to develop. The other thing I'll mention is when thinking about mutations that can happen in the chronic phase, and do they cluster with early transformation versus late transformation? Interestingly, the mutations that we see kind of on the left side of this, so a DNMT3A, IDH1/2, so splicing mutations and epigenetic mutations tend to be correlated with early transformation. On the other hand, TP53, NRAS, and BCOR are associated with late transformation. So thinking about prognostic mutations in MPNs, when thinking about IDH1 and IDH2, they're associated with inferior leukemia-free survival in primary myelofibrosis. And then IDH2 is associated with that in both PV and PMF. You have your chromatin modifying mutations like ASXL1 and EZH2, which drive poor survival in PMF, and then in the case of ASXL1, PV as well. You have EZH2, as mentioned, and then in splicing mutations, SRSF2, SF3B1, and then, of course, TP53 in DNA repair. The other part of this graph that I'll call your attention to is when thinking about these high-risk mutations, they are underrepresented in chronic phase MPNs and overrepresented in accelerated blast phase MPNs. So they become enriched as the disease progresses, which can then offer some insights into how we would think about treating these diseases. So how do patients with blast phase MPNs fare? The short answer is unfortunately not very well. We have data that was published by Teferi and colleagues back in 2018 that looked at a large cohort of patients and really illustrated the fact that even as we move forward in time, so pre-2000, the 3-year survival was 0%. Even if we move to 2010 to 2018, 3-year survival was only 10%, showing that we had historically done very little to move the needle in accelerated and blast phase MPNs. Now, we know that since 2017, there's been a boom of newly developed therapies in AML, and oftentimes we borrow therapies from AML and then use them for accelerated blast phase MPNs. So we have a number of therapies such as our FLT3 inhibitors, IDH inhibitors. We, of course, have venetoclax, which is mutation agnostic. And now we have our menin inhibitors that have kind of graced the scene. So our group had a very simple question. We have all of these new therapies. Have we actually made a difference in accelerated and blast phase MPNs with these therapies? So before I get into what the outcomes are of accelerated and blast phase MPNs in the current era of therapy, one thing I want to highlight is de novo AML and accelerated and blast phase MPNs are not the same disease molecularly. So mutations that we commonly see in de novo AML, FLT3, NPM1, are virtually never seen in accelerated blast phase disease. On the other hand, there's enrichment for things like IDH1, IDH2, ASXL1, and TP53. And that's important because we cannot just assume that therapies that work in AML are going to work in accelerated and blast phase disease. The scatter plot to the right shows the same thing in a slightly different way. So essentially, the mutations that cluster right down the middle at a diagonal are seen at fairly similar frequencies in both AML and accelerated blast phase disease. Those that cluster further to the right show those that are overrepresented in accelerated blast phase disease, and those that cluster up above to the left show those that that are predominantly demonstrated in de novo AML. So again, things that jump out: TP53, SRSF2, TET2, RUNX1, IDH2. These mutations seem to be more represented in our accelerated blast phase population. So when we wanted to look at this question of accelerated blast phase outcomes since 2017, we needed a multi-center effort to do this. And ultimately, we put together a cohort of 202 patients to help answer this question. We also looked at how patients fared based on the initial therapy they received. So the three most common frontline therapies for accelerated blast phase disease are intensive chemotherapy, DNA methyltransferase inhibitor plus venetoclax, or DNA methyltransferase inhibitor either in monotherapy or in combination with other therapies such as JAK inhibitor. And what I want to emphasize is with intensive chemotherapy and DNA methyltransferase plus ven, there were slightly higher remission rates of around 40%. Whereas if you look at the remission rates in DNMTI-based therapies, it's more like 20 to 25%. However, when you look at survival, increased response rates do not translate to better overall survival. So the median overall survival of the entire 202 patient cohort was still less than a year, 0.86 years. And when you look at the three most common types of treatment, DNA methyltransferase, DNMTI plus ven, or intensive chemotherapy, there was no difference in median overall survival. And numerically, DNA methyltransferase inhibitor actually had the best median overall survival, which may suggest that response alone is not predicting survival, particularly because these patients are so at risk of complications of cytopenias. And being able to tolerate therapy and stay on therapy that offers disease control, even if we don't see a remission, may confer some sort of survival benefit. And then the last thing I'll mention is only 14% of patients in our cohort were treated on clinical trial, which in my mind is much too low given the fact that our standard therapies are not very effective for accelerated and blast phase disease. Now, the other thing we wanted to look at is, can we use AML-based risk stratification and apply it to accelerated blast phase disease? So we used a number of ELN prognostic criteria that are developed for AML and applied them to accelerated blast phase disease. And the short answer is these do not work very well. So we looked at the fit of the score by something called a C index. And basically a C index of 1 is perfect. A C index of 0.5 is no better than chance or a coin flip. So if you look at the C index of these various scores, ELN 2017, 22, 24, and even the refined 24, the C index is right around 0.5, 0.6 at best. So they only have very moderate effect at predicting outcomes in accelerated and blast phase disease. Now, when we look at the individual mutations that have prognostic impact, IDH1 is a favorable risk mutation, or sorry, IDH2 is a favorable risk mutation in accelerated blast phase disease. And then there are several high-risk mutations that were noted: SRSF2, TP53, JAK2, DNMT3A, NRAS, CALR, and MIPL. The other thing I want to highlight is, as we see in all myeloid malignancies, TP53 is a bad actor when thinking about accelerated and blast phase disease. And single hit versus multi-hit does not seem to have a difference. TP53 mutation, even in a single gene, is very bad in accelerated and blast phase disease. So one kind of carve out that I want to mention when thinking about transplant for these diseases is there may be a role for proceeding directly to transplant in accelerated phase disease without blast reduction. So this was a cohort of 35 patients with accelerated phase myelofibrosis that went directly to transplant without blast reduction. And their overall survival was actually similar to a cohort of chronic phase MF patients with a 3-year overall survival of about 65%. So in that rare patient where they have everything lined up for a transplant and they happen to be in the accelerated phase, you may want to think about proceeding directly to transplant without blast reducing strategies. Now, when we talk about blast phase, it's a different story. Blast phase MPNs unfortunately have very poor survival. And what I want to highlight in this graph is even in patients that we think are in a remission, going into transplant, median overall survival from transplant is only about 50, or is only about a year. It's only about a 50% overall survival at 1 year. So that tells us that what we define as remission in blast phase does not seem to correlate very well with post-transplant survival because patients still relapse. And that may be because this chronic phase MPN doesn't fully go away and allows for subsequent relapses to happen. So how do we improve outcomes? In my mind, there's really three things to think about. One is how do we identify the patients at highest risk of progression to accelerated blast phase? So intervention before they progress. Studying the role of earlier treatment in high-risk MPNs, including accelerated phase disease. So intervening with transplant, maybe something like a JAK inhibitor or interferon that may have some anticlonal effect in, say, PV or ET that could reduce the risk of progression. And then the last bucket in my mind is studying the role of targeted therapy in these diseases. One particular target that's of interest to me is IDH mutations in accelerated blast phase disease. So IDH mutations are not unique to myeloid malignancies. They're seen in things like cholangiocarcinoma, glioblastoma. And really what happens is when you have mutations in IDH1 and IDH2, you have increased levels of the oncometabolite R2HG, which then leads to epigenetic changes that promote cell proliferation. Now, in IDH, when we think about IDH mutations in AML, it's actually been a target that we've been looking at for quite some time. And we have 3 approved inhibitors in the United States, ivosidenib and olutasidenib for IDH1, enasidenib for IDH2. So with that in mind, 5 years ago, our group wanted to characterize how patients with accelerated and blast phase disease respond to IDH inhibitor therapy. So this was a cohort of 8 patients, so a small cohort, all of whom had IDH2 mutations, and all of whom received enasidenib. And what really stood out to us is 4 of these patients had a response of a year or greater, and our longest responding patient was on an IDH inhibitor for over 4 years, demonstrating that IDH inhibition does have a chance of offering durable remissions in accelerated blast phase disease, which is not something we see with chemotherapy or DNA methyltransferase inhibitors or venetoclax-based therapies. One thing that we did note, though, is that the chronic phase MPN sticks around in patients that just receive an IDH inhibitor. So the acute leukemia component of disease gets well controlled, but the chronic phase stays. And that's demonstrated by slides from one of our patients. So when you look at the pre-treatment slide, for example, the peripheral smear, lots of blasts. Post-treatment, you see nice mature neutrophils. But when you look at reticulin staining, there's significant fibrosis that's seen both pre and post-treatment, demonstrating the chronic phase MPN. Patterns of progression that we've seen really are that the chronic phase MPN mutations tend to stick around, and then when patients relapse, they typically acquire additional high-risk mutations. And that was seen in all 3 patients that we had sequential molecular data for. So diagnosis, best response, and relapse data. Other groups have since looked at the use of IDH inhibitors in accelerated blast phase disease and have found kind of similar outcomes to ours, in that there is some patients who have a durable response, and in patients that achieve a remission, you could expect a response of 18 months or longer even. The other thing I'll mention is we don't fully know what the best approach is to treat these patients. So this was work done both by the Mayo group and our group that looked at frontline therapies in IDH mutated accelerated blast phase disease and compared HMA-VEN to IDH inhibitor-based therapy, and survival was identical. In my mind, the way I interpret this is the reason patients do well, or I should say better, when they have an IDH mutation is that you have more therapies to offer them. You can sequence them from IDH inhibitor to HMA-VEN, from HMA-VEN to IDH inhibitor. On the other hand, for patients who don't have a targeted mutation, once they progress on whatever therapy you offer them, you don't know what the next best option is to give them. So given the fact that IDH inhibition has promise in accelerated blast phase disease, but it doesn't get rid of the chronic phase MPN, there's been a lot of interest to think about a role for combined JAK2 and IDH inhibition. So this was preclinical data published by McKenney and colleagues now several years ago that looked at murine models of co-mutated JAK2 IDH mutated blast phase. And in these murine models, when you combine the two drugs together, you saw blast eradication, but you also saw reduction in spleen size and normalization of splenic architecture, suggesting that there is synergy to this combined approach. This has been looked at with ruxolitinib plus enasidenib for IDH2 mutated MPNs. And again, durable response is seen, small numbers though. We're now conducting a very similar study in those with an IDH1 mutation. So ivosidenib plus ruxolitinib in IDH against MPNs. Now, there are several other treatment approaches that have preclinical rationale. So BET inhibition, LSD1 inhibition, HIF, poly-ADP ribose. So lots of treatment strategies with preclinical rationale. The time has come to now actually start investigating these therapies prospectively. We cannot continue to treat accelerated blast phase disease with AML-based therapies because they simply are not very effective. So this, I think, very nicely outlines the different targets that we're looking at. So again, you have your IDH inhibitors here. You have venetoclax and navitoclax that are looking at the anti-apoptotic proteins. You have iadademstat and bomedemstat that's here. You've got, of course, your DNA methyltransferase inhibitors, azacitidine and decitabine. And what I want to focus on is LSD1 because I think that's a particularly promising target. So LSD1 is ubiquitously overexpressed in MPNs and plays an integral role in epigenetic regulation and maintaining bone marrow hematopoiesis. LSD1 inhibition can inhibit thrombopoiesis, erythropoiesis, and granulopoiesis. Importantly, this is a reversible effect. It also reduces NFE2 levels, which is implicated in the production of IL-8, so the inflammatory mechanisms of MPNs. In murine models where LSD1 inhibition was investigated, demonstrated benefit in both JAK2 mutated and MPL mutated models. Now, bomedemstat is the LSD1 inhibitor that's been studied most in MPNs, primarily in the chronic phase of disease. So this was a study in ET, a phase 2 study that looked at using bomedemstat in patients who already had received hydroxyurea. And what was found in the patients who were evaluable for response is a 94% platelet response rate, and many patients had a VAF reduction as well. The most common adverse effect was abnormal taste. Bomedemstat's also been investigated in myelofibrosis, both in combination or as a solo drug. And again, modest spleen reduction, but a significant amount of symptom score reduction. So bomedemstat kind of demonstrating that there's a role for LSD1 inhibition, at least in chronic phase MPNs. How about accelerated and blast phase MPNs? And that's where we are looking at a drug called iadademstat, another LSD1 inhibitor. So the reason we got interested in iadademstat is that there is a study looking at its use in AML. So the ALICE trial used azacitidine plus iadademstat in newly diagnosed AML in patients very similar to those that were included on the VIALE-A trial for aza-ven, so patients unfit for intensive chemotherapy. So the response rate was about 50%, with most responses within 2 cycles. I will say at the recommended phase 2 dose, the CR rate was actually 64%, which is very similar to what was seen with azacitidine plus venetoclax. The most interesting part, though, is when you look at patients who responded based on mutations, we saw high rates of response in the mutations that are overrepresented in accelerated and blast phase diseases: TP53, RUNX1, IDH, ASXL1. So that led to us developing a randomized study of oral decitabine plus or minus iadademstat in accelerated and blast phase MPNs. And with that study is currently enrolling. We're hoping that this will be the first randomized study done in accelerated blast phase diseases and allow us to start generating some definitive randomized data to help us decide what therapy to use for these patients. Our current approach to accelerated and blast phase MPN is summarized here. So NGS is critical because if they have an IDH mutation, you can think about using an IDH inhibitor. For those that are in the accelerated phase, you can think about proceeding directly to transplant. We highly encourage clinical trial options if they're available. And in the absence of clinical trials, for those with IDH mutations, we tend to use IDH inhibitor-based therapy. For those without IDH mutations, we typically use HMA-based therapy. We don't really use intensive chemotherapy for accelerated and blast phase disease at our institution anymore. And then the ultimate goal should be to try and get to allo transplant in patients where disease control is achieved and they are a transplant candidate. So let's go back to our case. So as a reminder, this patient had post-PV myelofibrosis, was on ruxolitinib for about 18 months, and then progressed to blast phase with an IDH2 mutation. So he was enrolled on a clinical trial looking at enasidenib plus azacitidine, achieved a complete remission, and continues to be maintained on therapy. His chronic phase MPN persists, and he's now currently being reevaluated for allogeneic transplant. So in summary, risk factors for progression to accelerated blast phase disease include the acquisition of high-risk mutations. Unfortunately, we have not improved outcomes very much for accelerated blast phase disease, even with all of the new AML-approved therapies we have. And then IDH inhibition seems to hold particular promise in this disease state. And another potential target is LSD1 inhibition, which is what we're looking at right now. So with that, I want to acknowledge the leukemia group that I work with at the University of Chicago. It's an incredible group of mentors and colleagues that I get a chance to learn from every day. Of course, the rest of our clinical team, our patients, and then I am supported by an early career investigator award from the National Cancer Institute. So with that, thank you so much for your time. This is my email address, my Blue Sky, and I'm happy to take any questions at this point. Thank you so much for your attention.
Thank you, Dr. Anand Patel. Wonderful lecture. Fantastic. Lovely to listen to you, as always. And now I request all our discussants to please put the hand raised sign so that we can start our question session with Dr. Anand Patel. Yes, Dr. Roshni Pandey, ma'am. Please go ahead.
Good evening. Thank you for that excellent lecture. Wanted to know, does it make sense to do the molecular testing upfront at diagnosis to decide whether the patient is high risk for progression to accelerated phase of blast crisis?
I would advocate yes. I mean, I think part of it depends on the availability and ease of molecular testing, but as of right now, unfortunately, once someone progresses to accelerated or blast phase disease, with our current therapy, it's too late. We've already missed our opportunity most likely to cure them. So if you have someone with, myelofibrosis who's maybe intermediate risk, but they also have a ASXL1 mutation or something, and they're an excellent candidate for transplant, I would advocate you should probably think about transplanting them because their risk of progression to accelerated or blast phase disease is quite high. And if and when that happens, our ability to achieve a remission and get them to transplant is not very good.
And how do we follow up patients with myelofibrosis on ruxolitinib? Means, they're going on for 5 years, 7 years on the drug. So when do we start suspecting that they're progressing?
Yeah, so I mean, the main thing I would look at is if you're developing worsening cytopenias after some period of stability. And then, of course, if you're starting to see peripheral blasts, those would be the things that would be the most indicative of someone having a progression event on ruxolitinib. And then if those things are happening, I would think about getting not just a repeat bone marrow biopsy, but probably reprofiling their disease, because we know that accelerated blast phase disease is largely driven by acquisition of new mutations. So they may not have had a IDH mutation initially, but it then develops at time of progression. Unfortunately, sometimes that happens with TP53 as well, which of course is not very helpful to us because then we just know that it's going to be a very high risk disease.
And what was that C index you was talking about?
Yeah, so C index is basically a way of looking at how well a prognostic score actually differentiates the different groups. So you can use C index to basically see how well does a model fit the patient population. So a C index of 1 means that you have the perfect model, which we know never exists, but that's what it is. And a C index of 0.5 is a coin flip. It's basically chance. So when we use AML-based prognostic criteria for accelerated blast phase disease, the best C index we found was 0.6, which tells us that these AML criteria don't work very well for accelerated and blast phase disease. The main reason for that is because almost everyone with accelerated blast phase disease behaves as if they have adverse risk disease. So you don't really get differentiation between a favorable risk, intermediate risk, and adverse risk group. They all end up kind of behaving as if they have adverse risk.
Thank you so much.
Thank you, Dr. Roshni Pandey. Dr. Gopinathan, your question.
Good evening, sir. Thanks for that excellent overview. So my question is, what is the role of navitoclax? Is it still accessible for use, or it is still in trials, and where is it placed right now in the accelerated phase?
Yeah, unfortunately, I think as of right now, AbbVie, which is the company that led the development of navitoclax, is no longer developing it. So there was a phase 3 study of ruxolitinib plus navitoclax in myelofibrosis, where it showed improved spleen response, but there was no improvement in symptom score. So ultimately, their navitoclax was not approved for myelofibrosis. And because of that, the clinical development of that drug is largely stopped. I think mechanistically, a drug like navitoclax makes sense because MPNs are much more BCL-XL dependent than they are BCL2 dependent. And that is seen clinically because these patients don't respond very well to venetoclax, which only hits BCL2. It does not hit BCL-XL. So I do think that as a class, looking at the further development of BCL-XL inhibitors, even if they're not navitoclax, will be very important and may, again, offer some sort of therapeutic strategy for accelerated and blast phase MPNs.
Yeah, and second question is something more related to the biology. Why do we see that difference between here the TP53, NRAS, and BCAR giving a late progression, particularly with MPNs, whereas the other ones, the NRAS, the spliceosome mutations, they are seen with early progression? Is there some biological explanation for that?
Yeah, it's a good question. I think part of it is that we know that TP53 is a very common CHIP mutation as well. So I wonder if some of these patients that have early detection of TP53, it's more like a very low VAF TP53 mutation, and then it just needs that additional amount of time. And unfortunately, once progression happens, that TP53 mutation is probably the driver of it, but it kind of is in this chip-like state for many years, it would be my guess. So, but I don't think we fully understand the biology of why we kind of see the late progression versus early progression.
Thank you, sir. Thank you so much.
Thank you, Dr. Gopinathan. Dr. Shilpa Gupta.
Thank you, Dr. Patel, for a very excellent lecture. So I'll just discuss a patient of mine, around 60-year-old, incidentally detected to have ASXL1 mutation along with JAK2 mutation. Patient was referred in view of polycythemia, classical polycythemic features, but on NGS, we got these two mutations. Patient has had bleeding piles, so very well controlled with respect to polycythemia, even without cytoreductive agents. So in this particular scenario, when the patient is very well controlled, does this mutation, additional mutation, should it alarm me, or should the patient be on a more stringent follow-up, or is there anything that I should look for because he has an additional mutation?
Yeah, it's a great question. So we do have the same group, the Mayo group that developed the MIPS scores for myelofibrosis, has developed them for PV and ET as well. So the MIPS PV and the MIPS ET. Ultimately, even high-risk PV and ET, survival is measured in many, many, many years. So, for example, early transplant is not something that we are doing for patients with high-risk PV or ET just because the risk of transplant is still much higher than the benefit for them. I do worry about this patient having an ASXL1 mutation, and I think slightly closer follow-up. So for many of these patients, I'll try to see them every 3 months or so if I can, or at least have them get blood work and have it sent in to me every 3 months or so, just so I can kind of monitor it. That's the main thing I do. And again, if my suspicion of if they reach what that honeymoon period, so all of a sudden you find that someone who needed cytoreduction previously is not needing it anymore because their hematocrit is controlled on its own, or they're requiring no more phlebotomy. They used to need phlebotomy a couple times a year, and now they don't need phlebotomy at all. those in my minds are almost kind of warning signs that the disease is starting to become fibrotic. And that would also be things that I would think about pushing me towards repeating a bone marrow assessment or something like that.
Okay. Another case scenario is actually I have a old lady, a 72-year-old with post-PV myelofibrosis. She has relatives in US. She is presently on ruxolitinib along with she's not very well controlled. I have repeatedly counseled her for undergoing a clinical trial. So maybe you've provided your email ID. I would mail some details to you and see if she's eligible for your clinical trial. And if it's possible, is it doable? Patient has earlier taken treatment even in the US.
Yeah, so, I think there are a number of different myelofibrosis studies. So, ones that we have at our center, there's a novel pathway called PIM kinase that's been investigated. So there's a PIM kinase inhibitor called nuvisertib, which is being studied both as monotherapy and in combination with JAK inhibitors. And that drug has been presented as an oral abstract at ASH the last couple of years with kind of the early phase data, which has been quite promising. So that's the chronic phase myelofibrosis study we have available to us, along with a study for IDH1 mutations. And then for patients with accelerated and blast phase disease, we have this LSD1 inhibitor trial, which is available as long as someone has not already received a DNA methyltransferase inhibitor. But if they've only received a JAK inhibitor, then they are eligible for that.
Sure. Thank you so much. I may write to you. Thank you.
Yes, I'll keep an eye out for your email. Thank you.
Thank you, Dr. Shilpa Gupta. There is one question from Dr. Rama. Essential thrombocytosis in blastic phase with acquired von Willebrand disease. What would be your current approach?
I mean, it's difficult. My thought would be it comes down to if they are a transplant candidate versus not. If someone is a transplant candidate, I would probably still use azacitidine plus venetoclax or decitabine plus venetoclax. Now, I will say it might be worth at least using some hydroxyurea initially to kind of drive their platelet count down and hopefully allow their von Willebrand to recover. So that way they're not at high risk of bleeding when you induce them. So I would maybe try that, see if the von Willebrand factor kind of recovers or normalizes, and then proceed pretty quickly to azacitidine plus venetoclax. Now, for patients who are not a transplant candidate, you could certainly think about just using an HMA by itself to offer some long-term disease control, given that the addition of VEN does not seem to have a survival benefit in accelerated and blast phase disease.
Thank you. Another question she has is, what is the TP53 VAF cutoff in MPN? Is it similar to AML?
Yeah, so we kind of use the same definitions for single hit and multi-hit in MPNs that we do for AML because we don't have kind of specific criteria that have been developed. So we borrow from the WHO and the ICC criteria to define single hit versus multi-hit, or single allele versus biallelic, whatever you want to call it. But yeah, so a VAF of over 10% in a single TP53 mutation, or if it's over 50% in one mutation, we think of that as being multi-hit disease.
Thank you so much. There are no more questions in the chat box. Anybody else has any other question? Yes. Yes, Dr. Gurprit. You can open up your video. You can ask your question. Dr. Gurprit Kaur.
Good evening, sir. Am I audible, sir?
Yes, you're audible. Please go ahead.
Thank you, Dr. Anand. That was a very nice lecture. My question to you is that sometimes as a pathologist, we encounter situations where, let's say the hemoglobin is 17 gram%, but the morphology on the bone marrow doesn't really give us a picture where it looks like a PV. However, symptomatically, the patient has symptoms which look like PV. So in such a case, if we're not clinically able to, make that diagnosis, would you still go ahead and treat the patient as a PV? We counted this so many times in our lab.
Yeah, that's a great question. I mean, and then do you end up calling them MPN unclassified, or what diagnosis do you end up giving them?
No, so what I've done a couple of times is said that this looks like something which is progressing into a PV because it doesn't have clear-cut morphological features, but so I just give it like a pre-PV kind of a picture on bone marrow, and the JAK2 also sometimes turns out positive. I mean, it is there that has a decent VAF. So how should we go about these cases in your idea?
Yeah, it's a good, I mean, theoretically, I mean, technically for WHO, you can make a diagnosis of PV without even a bone marrow biopsy if they have a JAK2 mutation, have a suppressed EPO, and meet the hematocrit cutoff. So, you know, I think for those patients that are JAK2 mutated, I would still treat this as if it's PV if they're kind of meeting these other diagnostic criteria, even if the bone marrow is not classic for it. Where it becomes difficult is if it's a JAK2 negative patient, or say, let's say it's JAK2 CALR and MIPL negative, then, you know, I really wonder, is this a secondary erythrocytosis? Is it sleep apnea? Is it supplementation? Is it EPO production from a different tumor? You know, something like that. So I would be very cautious for the patients who have JAK2, MIPL, and CALR wild type to make sure that a secondary cause of the erythrocytosis is not being missed.
Right. Thank you.
Thank you, Dr. Gurpreet. There is no other question. I think yes. So anybody else, any other question? Well, in that case, there are no more raising signs and there are no more questions in chat box. Thank you so much, Dr. Anand Patel. Wonderful lecture. Fantastic. Nice to listen to you as always. And also I thank all our discussants to participate during this webinar, and meet you tomorrow, 11:30 a.m. And I now hand over to Dr. Suyash Bharat for the final vote of thanks. Dr. Suyash, are you there? I think he has left. Fine, sir. Thank you, Dr. Anand Patel, once again. Good, fantastic lecture. Lovely to hear to you.
Thanks so much for having me. A pleasure as always. Thank you so much for the excellent questions. And yeah, I look forward to joining again in the future.
Thank you so much. Thanks a lot.
Take care.